The broadcast is now starting. All attendees are in listen-only mode.
All right, good afternoon, everyone. My name is Jackie Leiser, and I'm a manager at CAQH Core. Thank you for joining us for today's webinar. This is part 2 of our CAQH Core and X12 collaborative series on the 270 and 271 transaction, standard, and operating rules. Before we get started, I just want to review some logistics on how to access our webinar materials. If you take a look at the GoToWebinar menu, you can download the slides right now directly from the handout section. The slides and recording for today's session will also be available on our events page after the webinar, and we'll also email it out to all attendees and registrants in the next 1 to 2 business days. I do want to quickly remind everyone that there is a part 1 to this series that you can watch on our YouTube channel. I've linked it to this slide, so if you go ahead and download the slides or receive them after the webinar, you can go ahead and just click that link and watch the introductory webinar, which is part 1 of the series. Before today's speakers introduce themselves, I do want to highlight that much of the discussion today is going to be driven by all of you attending today. Please participate by submitting questions at any time throughout the presentation by entering your question into the questions pane in that lower right-hand corner of your screen. There will be a substantial Q&A portion in the second half of today's webinar, so we hope to get to a lot of your questions. And with that, I'd like to thank our speakers for joining us today, and I'm going to go ahead and allow them to introduce themselves. So Donna, I'll turn it over to you first.
Thank you. My name is Donna Campbell. I am a product manager for a product that's referred to as the provider portal and provider connectivity area. So our acronym is PPPC. I work for Blue Cross Blue Shield of Illinois, which is a plan under the Healthcare Services Corporation organization, and I am also a WEDI subwork group co-chair for the Eligibility and Benefits subwork group, and a co-chair along with Everett Ford of the ASC or the X12 TGB, which is the insurance task group, work group for eligibility and benefit information.
And I'll quickly add, Donna also was the co-chair for CAQH Core when we developed the recent set of eligibility operating rules that were just published in April. So thank you, Donna.
Thank you.
Everett, would you like to go next?
Sure. I am a product manager for Optum as part of United Health Group. I deal with validation product. It's buried in certain other products. The name of it is Velocity, and that's spelled with an EDI on the end of it. And it basically looks at X12 rules for all types of transactions and validates whether or not that transaction follows TR3 guidelines and X12 rules and generates errors if it doesn't. That's part that is a core product that's part of multiple other products that validate different types of software. I started out in the customer service environment and developed expertise through handling questions like this, and transitioned in 2018 to actually working with the developers on the core product. I joined X12 as a member in late 2018 and started attending meetings in 2019 and have played a role since then. And I'm happy to share duties with Donna as a co-chair.
Great, thanks, Everett. I'll go ahead and introduce myself too. My name is Bob Bowman. I am the principal here at CAQH Core. I've been here for nearly 15 years, writing operating rules for HIPAA and non-HIPAA transactions to make it more easy to get data where it needs to be for usage, both for the provider and the health plan perspective. Before joining CAQH Core, I was the EDI manager at Humana for both their provider portal as well as all their EDI and paper transactions. So managed the paper claims at Humana too back in the day. Even prior to that, I worked at a clearinghouse that worked in the Medicaid space. It has gone through several iterations now, but working in the Medicaid space also for their provider portal transactions for eligibility specifically, as well as claim status transactions. So with that, we can move over to our agenda slide. And as a way for introductions, we have a couple of topics that have bubbled up from our first session earlier this year, back in July, that we wanted to bring forward into this session, just as a way to kickstart some of the conversation, because we know folks have questions about these topics. So we'll go into these, and again, feel free to please submit questions in your questions panel. We'll be bringing those in to the conversation as they come in, as we see them, and assess them and make sure they come in for that are topical. So if you have questions about the 835 or a claim, they're probably not going to be addressed, because we do want to focus the discussion specifically on the eligibility transactions and the interactions that take place between a provider, the tools that they use to submit these types of transactions, and then the responses that come back from a health plan relating the information about benefits. So again, try to make your questions topical, try to enter those in as much as you can. Again, you have the expertise from X12 folks on the line. I'll act like the expert on the operating roles today, and between Donna and Everett, we'll try to address as many questions as we possibly can during our kind of open-ended session. If the questions are related to other areas, we'll try to address those maybe towards the end in our Q&A session. We know there's lots of activity going on in the industry today, even with CAQH coming up in January with related topics for X12 and the core operating rules. There's lots of topics and moving parts within the regulatory world as well that are going on right now that lots of people are focusing a lot of energy on. So we'll have a QA session towards the end as well. And as always, we're always looking for folks to participate both with X12 and core. We'll have a couple of slides at the end just to wrap that up as well. So with that, we can probably move into our first topic, just way of introduction. Everyone knows that the HIPAA transactions are mandated for use. There's a sets of operating rules that are also mandated for use. I mentioned earlier that CAQH Core, along with Donna's help as a co-chair, published a new set of operating rules specific to the eligibility transaction, as well as updates to our infrastructure and connectivity last year. So there's existing rules that everyone is using related to both the standard and the operating rules. There's also new rules that were just published this year related to the eligibility transaction. So we want to be able to cover both existing and what you're required to do today, and potentially even the future requirements that, especially for those core certified entities, over the next couple of years, you'll be remediating your systems to build those types of capabilities to answer those types of questions that providers have around eligibility and benefit. So really moving into our next topic on the next slide, there is very specific things that are required or optional when it comes to the eligibility transaction, the 270 transaction, the 271 transaction. Moving into the next slide, you see, or kind of our first topic here is understanding the difference between a generic and an explicit transaction. Maybe I'll pause here and pivot to Donna. Maybe Donna, can you help explain what the difference is between the generic and an explicit inquiry related to the 270 and 271 transactions?
Sure. Right now, in the current 5010 version, our definition of generic would be the service type code 30. The service type code 30 on the inquiry or on the 270 has a different meaning than a 30 does on the response. So in terms of the 270, when someone submits a service type code 30, they're essentially asking for a few different benefits bundled under that one service type, which basically allows them to avoid having to ask for the 10 or 11 specific service type codes, which they don't need to do when they just ask the 30. The 30 on the response is not dubbed a generic response per se. It's an answer to the generic inquiry, or the 30 on the inquiry, but that response essentially will give an indication of plan coverage for that member whether or not they have coverage or not by way of the EB01 and then the EB03 having the value 30 in there, which is the service type code for health benefit plan coverage. And then we'll give additional information about that particular plan, whether or not it's a PPO, an HMO, if it has a particular name or program identifier that would go in EB05. So that's the generic. Just ask a simple question and you get a variety of responses without having to ask a variety of inquiries to get the variety of responses. And then the explicit one has essentially two definitions. One, they're both the same definition, but it's when you're not asking for a 30 and technically when you're not asking for a 60. So anything other than a 30 or for that matter a 60 can be treated as an explicit service type code, but in the 5010 TR3 it very explicitly, not to use the term again, identifies that an explicit inquiry is also that of what would tie back to an inquiry of a 30. So if you did a 30 on the 270 and it's mapped, so to speak, to the 10 or 11 service type codes that you have to return if it's a covered benefit at a plan level for a member, we'll use the numbers just for clarity, a 1, a 33, a 35, we'll say 47, that suite of numbers, those would be the medical, the chiropractic care, the dental coverage, the hospital. Then you have the office visit, 98, and you have the vision, the urgent care, the mental health. Those responses are explicit responses that are required to be returned when you have a generic inquiry. And as an explicit response, if you return those service type codes when you get a 30 in saying they are covered, when that provider asks if that 33, now asking for an explicit service type code because it is not a 30 and it is not a 60. When that provider asks for a 33, you technically need to give the same answer that you gave when the 30 inquiry came in and you return the 33 as an active benefit or service under the plan. So it's why the idea of it being explicit with two different themes exists, because one is an explicit response to a 30 and one is an explicit request with the explicit response. And so.
Great, thank you so much. I think hopefully that brought some clarity on the difference and the distinction between the two varieties or versions of an inquiry that a provider may send. And maybe I'll add that many systems, many providers automatically it defaults within your own application, whatever system you might be using, to a 30 because it does bring back a robust set of data related to that patient. But many systems do allow for the provider to change that 30 to something else that might be more specific for those explicit benefits. So if you're one of those specialty providers, like dental, like chiropractic, like lots of different services that fall within that set of any specialty really, or if you're perhaps a hospital looking for a specific type of benefit that's related to a stay or a procedure that you wish to perform, you, the provider, can enter in that explicit inquiry and gets explicit benefits back. On the next slide, since we're kind of getting into this topic, it might help clarify some of this. If we can move to slide 10. We do have distinctions within the core operating rules between not only an explicit inquiry, I'm sorry, the standard describes what is a generic and or an explicit inquiry. Within the operating rules that have been around for quite a long time now, since 2006, we have the idea of discretionary and mandatory. And this is a broad topic related to types of benefits. So I want to maybe clarify what is going on when we say discretionary and mandatory. When those explicit STC codes come in, because the provider is looking for something specific perhaps, there are certain types of benefits that we have deemed core, the core body, core participating organizations have defined as discretionary. And that means oftentimes that the code is either too general or generic. It might be really, really generic, like medical care, that might be so generic that you as a specialty provider might not understand what the results are coming back to you. Or the code is a carve out, like vision. You're sending in an AL to a medical health insurance company, but that's been carved out and is actually should be farmed or be sent to the vision beneficiary or health plan. So you have those types of benefits. Dental could fall into this, mental health. There's lots of different carve out benefits that exist. There's also the ability that the code might be related to a behavioral health or a substance abuse issue or benefit that is considered discretionary for privacy concerns. So we don't require health plans to return those benefits if it's one of these discretionary STC codes, because again, too generic, it's a carve out, they probably don't host that data themselves, being the medical carrier, or it's a behavioral health or substance issue and they're discretionary on whether the health plan decides to return that or not. The other issue is mandatory. That means if the STC code is listed as mandatory, the provider can submit that STC code and the health plan is required to return benefits specific to that STC code. So that helps hopefully define that particular issue. I know we've had one question come in, thank you, Christopher, talking specifically around dental benefits and what exists. The core operating rules as well as the standard do support explicit STC code, for example, 35 for dental care. That is considered discretionary because it's often a carve-out benefit. So a medical plan might not know what your dental benefits are. You'd have to submit that to probably a dental insurance plan to get those benefits. With the latest update to the core operating rules this past April, there are a number of new mandatory and discretionary dental benefits or dental STC codes that are now used and can be used. Again, the industry is adopting these new rules through time over the next 2 years. But you can go drill down into like 23, diagnostic dental, 24, periodontics, 26 is endodontics, 27 is maxillofacial prosthetics. So you can really get those really key specific benefits for that patient for dental now. Again, dental plans are implementing this capability now, but over the next 2 years, you'll see folks being able to, not only will providers be able to submit these explicit STC codes within their PMS system, the practice management system, but dental plans will be able to respond explicitly to what those benefits are. So that's just an example in dental, but every other specialty or type of STC code that is explicit can also be returned with that granularity and level of detail that providers really find helpful and useful. So hopefully that helps. Everett or Donna, any other topics around this that you might want to clear up, or maybe how you as your specific implementations of discretionary mandatory might help the industry?
Well, there's one topic that I did want to bring up that I think is definitely something that needs to be brought to people's attention just for awareness. There's, at least in the 270 that's proposed, that's there today, and within the confines of the operating rules that are mandated today, there is no expectation that a payer supports more than one service type code on the inquiry. And at the end of the day, when the implementation guide, it requires a payer support the 30 no matter what. No matter who, what, when, why, or how, you have to support a 30. And the operating rules, as we mentioned on the last call, are the floor, not the ceiling. And really the mandatory and discretionary service type codes are still just a subset of the larger list of codes that are within the TR3. It doesn't prohibit people from supporting beyond what's on the list that are listed in the operating rules, but there still is nothing either in the operating rules or in the TR3 itself that says that a payer has to support 2 or 3 or 4 service type codes on a response or on an inquiry. And then to that end, when the response gets generated, it's likely going to be whatever that first service type code is that came in the door to the payer. And depending on what system you have, how many hops it has to take, if there's a clearinghouse involved, or if there's multiple translators or a homegrown translator, the same way it went out the door from a provider doesn't necessarily mean it's the same way that it will come in the door to the payer. So the example is, let's say a service type code 133 and 69 were sent in on a 270 from a provider. It doesn't mean that the same order of 133 and 69 will be received by the payer. And if the payer ends up only responding to the one, that's likely because it's the first one that came in. If the payer actually got 69 in first, it's likely that one's going to get processed and the other ones may not. So right now in 5010, there's no guarantee that a payer will support more than one service type code. And with that, there could be a chance that there's some unanswered questions that were submitted on a 270, and that could lead to some confusion when the response is returned to the provider. I don't know if Everett, you want to add anything, or even Bob, if you have something from an operating rule standpoint or CAQH core standpoint.
Just from a validation perspective, I can confirm precisely what you're saying. We support multiple payers, and there are it's very arbitrary what service type codes any individual payer chooses to support. And we've had multiple questions from providers that would try to say that the payer was mistaken because their specific service type code that they requested didn't get dealt with. And, you know, we can't validate those in a negative fashion because of the way the TR3 is currently written. So 100% what you're saying.
And maybe to add to the conversation around this particular topic, there can still be variability, even with a standard and even with operating rules. How the back-end systems have implemented both can still vary. And some of the challenges that providers may continue to experience or have, they might be able to work with their liaison that they have at that health plan to understand how things are built. We do have a companion guide requirement. If you conduct the transactions as a health plan or a clearinghouse, you must publish a companion guide. And often in the companion guide, there might be some guidance to providers and to other implementers of the transactions on what the expectations are. And here's how we've implemented the standard in the operating rules. Here's how we would send back multiple STC codes if we support them or not, right? I think Donna mentioned some plans only have implemented to receive one STC code. Others might receive 10. So that variability still exists in the marketplace today. So if you're still experiencing those types of challenges, that, hey, we'd like to have this and this benefit, send it one time and get one response with both. If not, the provider has to send individual STC code transactions and wait for the response one by one by one by one. So that, again, leads to a little more burden on the provider side because of the variability that exists within implementations. So I'm sure providers through time have learned how each plan kind of does this on their own, just through experience, but it can change. And we hope to see some positive change because of the updated operating rules. We'll have some additional STC codes that are going to be mandatory to support. I think Donna mentioned that the existing 5010 version that is HIPAA mandated and implemented across the country, there are, Donna, I can't remember the right number. I think I try to count it every time and I always lose count. It's like 180 or 220 different STC codes within 5010, somewhere around 200 maybe. Not all of them are required to be supported by the 5010 requirement, right? Just as here's a list. Every health plan may or may not accept that STC code, that explicit STC code for those specific benefits. They might dump it back to a 30 response because that's allowable if it's not a core required one for the initial set of operating rules from 2008. Again, we've added as a stepping stone for the industry to implement the latest version of operating rules over the next couple of years. We've added on to the 50 codes that we had before to make it now about 130, 50 code, right? We've upgraded the number of explicit STC codes that must be supported. And I know we have the potential in the next version of X12 and potentially the next version of HIPAA with 8020 to accept all of the STC codes as explicit and mandatory. So health plans have to respond to all of them. So again, you see this stepping process, phase process of implementations of the codes might make it helpful. So that can be really helpful for everybody. I'm going to move us on maybe to the next slide and next topic, still staying within this coding realm. Because there is the capability within the standard today, maybe I'll have Everett and Donna talk about it, of the supporting just a procedure code. The industry has adopted STC codes based within the transaction, within the standard itself, and oftentimes, and I think Donna and Everett alluded to this too, that the STC code is a standard code, but how that might be mapped on the back end with your internal proprietary codes and what those benefits mean to your claims adjudication system, to your eligibility and benefits mapping product that you have, it then goes back to the claims, that's all proprietary. So you might have something like surgery as an STC code or chiropractic, but your internal coding system might have 3, 4, or 5 dozens of internal codes that have to be mapped to that one code. Those benefits can be all different, right? And the co-pays, the co-insurance might exist for some benefits and not for others, but you have to dump everything into a kind of a generic code on the STC code level. So the standard does allow for procedure codes. Isn't that right, Tom?
Yes. And there have been questions recently that have been discussed about what type of procedure codes can the standard support. And the standard supports the procedure codes that are qualified in the TR3 with the qualifiers that represent different procedure code categories. So some of those would be the American Dental Association codes, CPT codes, HCPCS codes, ICD-9 codes. They're still in the TR3 because there's some eligibility companies that support eligibility, 10, 15, 20 years in the past. Even though they're only required to go a year in the past, there are some companies that can go as far back as they have benefit details and membership details in their system. There's home infusion codes, and there's the NDC codes. So there are a lot of different procedure codes or flavors of procedure codes that can be supported. And then naturally we have the ICD-10 codes. And with that, if there is a specific way that if you don't support procedure codes and you can't determine benefits and there's no other information that you can return with a procedure code, you would technically, like Bob said, treat it like you received a 30. The same goes for any service type code that you really can't support. So maybe you're a carve out, for example, and you receive a service type code for a benefit that would be in your system if you were a different type of healthcare insurer, but because you're not, or you don't offer for that particular membership, that particular benefit, so therefore you don't support it. Hopefully it's identified in your companion guide what type of benefit inquiries you support for your different lines of business or different types. And then when that is received and you can't support it, you would treat it like you received a 30, and you would return those medical care, chiropractic care, dental, all the coverages that do exist for the member for the data service that is either on the 270 or the date the transaction was processed, and return it as if the procedure code was never submitted or the service type code that isn't supported was never received. And the same goes for that procedure code. So if you received a procedure code 99213 and it's a CPT code, so it would have the qualifier CJ, and then you would have 99213. Maybe there's a modifier, maybe there isn't, and you don't support that level of inquiry, you would technically just treat it like you received a 30, and you would return the host of required service type codes that would be returned if they were covered benefit for a member at the information sources level on their system. So you'd return the the 10 codes or 11 codes, the diagnostic, the medical care, chiropractic, physician office visit, urgent care, mental health, et cetera, et cetera. The other thing I wanted to mention is there's a lot of people think that just to return a procedure code, you have to have one on the inquiry. So if you have in your system the ability to, like Bob mentioned, maybe map a procedure code to certain contract details that you have, even if a procedure code wasn't received, but maybe there's some extra information that you need to return to a provider that is about a specific service type that can go further in detail, narrowing it down through a procedure code. There is nothing restricting or prohibiting a response from containing a procedure code, even if you didn't get one on the inquiry. So a good example that I know we've used in particular in my company is when you have surgery. Surgery is so generic and it's so difficult to figure out whether or not it's covered because it's really dependent on potentially diagnostics. Like, are you diagnosed with a reason to have the surgery? It could be any flavor of surgery. It could be whether it's inpatient or outpatient, if it's elective or not elective. There are so many different variables to the concept of surgery. But maybe no matter what, your policy for that particular member is always going to cover bariatric surgery. No matter what, that's covered on your policy. You obviously have to qualify for it and may have to have a diagnosis to suffice to get it, but it is a covered benefit on your policy, and there's no way necessarily with a service type code other than asking for surgery can you drill down to that if a payer can't support the inquiry at the procedure code level. So maybe you do return that surgery is not covered and then use an exclusion, the EB01 value that says exclusion for bariatric, or the vice versa might be that surgery is covered, maybe bariatric's not covered, and you say that bariatric surgery or the procedure code that would go with bariatric is a non-covered service. So you'd have an EB01 equals I for non-covered with that particular procedure code being returned. You didn't have to get the bariatric surgery procedure code in for you to be able to return that surgery is a covered benefit, but this particular type of surgery is excluded and non-covered.
And that is just an example of surgery.
Just a tiny example.
This
may or may not even be real.
Right. No, but but I think it plays to the fact that health plans or those that respond to an inquiry have the ability to make their back-end systems sophisticated, so providers can get that drill down information that's specific to a member's benefit. And this is really key if you have products that are specific to certain populations or certain types of care or certain types of care delivery. If you are a specialty health plan and you have very specific types of benefits for certain categories of folks, you can be really explicit in what's covered, what's not covered, where the insurance variability is for surgery, for those specialty types of care. You don't have to provide, or you don't have to give or respond to a provider with generic information at a very high level. The standard today already, right, 5010, allows for health plans to provide very detailed levels of information back to the provider. So it's actionable. They don't have to pick up the phone to find out what is covered under bariatric surgery, because that can actually be returned today in the 5010 version of the X12 transaction. I know we have a couple other questions are coming in. Is there an easy way to know which payer supports procedure codes? Tough question. And let me say it this way. Health plans, some of them are going down that pathway of supporting specific categories of service. And with the latest update in the operating rules that we just published in April again, we do require health plans to support 4 different categories of service. Again, this is kind of a phased approach to get health plans used to responding to this level of specificity. Those 4 categories of service include physical therapy, occupational therapy, imaging, and surgery, just the example that Donna provided. So those allow the health plans to start building out responses to those specific procedure codes. And again, the provider may send in that one of those very, very specific procedure codes, and use a health plan will have that back-end mapping for those benefits, that benefit package that that member has, and understand that at a maybe today is a STC code level, but for these 4 categories of service, you can start building out and mapping out what that would look like for those types of procedure codes for, again, physical therapy, occupational therapy, imaging, and surgery. Those were the ones that the core participants found the most important for providers today. So you'll see health plans start building out those systems to support procedure code inquiries at that level. I don't know, Donna or Everett, are you aware of any health plans? Do you, Donna, do this yet, or have plans to do it? I don't want to put anyone on the spot, but it might give folks an idea that, hey, there's some traction here, there's some movement in this direction. I do know of a couple of health plans that have implemented parts of this for certain markets, for certain members, so it's really nuanced right now because it's so new, but it does exist, it is out there.
Yeah, I can say from my organization standpoint, we are still doing deep analysis on what it's going to take. Of course, I have, strong faith that we can do it, and it will be very helpful. Just plug for the operating rules round 2 when they come forward. These new ones, when they require those 4 categories, that will really kickstart our organization's effort into gear. A lot of what our organization, and I'm sure a lot of organizations are the same way, until it's been required by law, it takes a village to get it to go, because there's so many other priorities. And until that ask becomes a reality, a lot of it's just thinking about ways that we will address it without actually implementing it. What we have done is we've worked with our vendor, specifically Availity, and Availity has worked with us to build out the support of procedure code-based inquiries for the determination of prior authorization specifically. So we aren't necessarily supporting the benefit level inquiry part, where we're advising whether or not a procedure code is covered and what the deductible or copay and coinsurance are when it's tied to a procedure code, but we are at least saying we know that this particular procedure code requires a prior auth, so at least that part is managed, and that level of workflow that would have to get done is done. And often in that process, they'll get a little bit more information about the benefit coverage capability. And it also gives an indication about medical policy, which isn't necessarily part of the 270, 271. Medical policy is pretty much a completely different beast than whether or not a benefit is covered or not.
Right, exactly. Everett, any insights on how Optum is moving forward with potential procedure code?
We've had discussions around the topic, and specifically there's been some interest around the notion of people submitting specific procedure codes and then getting a response on those specific procedure codes. There, to part of what Donna said, the notion that a benefit would be tied on the back end of a procedure code, to my awareness, that hasn't really even been addressed internally as far as anyone's brought my attention to it. But the whole idea, we're very keen on dealing with complex medical situations. If there's situations of complex care, like for example, someone may have cancer and they may have diabetes at the same time. They have a very complex set of needs, and the ability to support specific procedure code requests would ease the process greatly in that. And there's been some talk and discussion around doing that just from a complex care perspective, just to give an example.
Great, thank you. And those are even different, I'm going to say, categories of service that the core rules core operating rules haven't considered yet. Or again, the core participants, we survey the participants on what services should be the first approach. But it's good that the industry is considering other categories of service because of the needs of their members, right? And definitely certain types of comorbidities or disease management is really impactful on how the industry can make strides in meeting the needs of the providers when it comes to the types of data that they need for those delivery of care, right, options. So I think it's really important. Thank you, Everett. I think we'll move on to our next topic, and this is related to the AAA error codes and improving the use of the AAA error codes. This came up also from our summer session. We can move into the next slide and give you just a little background on what we mean by AAA error codes. There's lots of different ways that the transaction, 270-271 transaction, uses errors and reporting errors back to providers and how that might work. We do have even higher level types of errors, a 999 error that is generated for very specific reasons. These are types of acknowledgments that can be used either for rejection, an acceptance, or an acceptance with error as well. So these types of interactions at the X12, I'll call it the X12 level, take place today. Hopefully you're receiving those types of transactions. And then the 271 response can also send back to very specific types of errors. Maybe, Donna, do you want to maybe give a quick overview of what types of errors or how this works today with 271 coming back with errors?
Yeah, today, the 271, it's pretty clear in there that when you have an error, there's some, specifically on the EB segment in the 2110C or D loop, technically you're required to send back the EB loop unless you had a rejected response. So there is right now no way to identify if a rejection response is so significant that it has to halt the whole response, and then essentially you return the error and you give that indication that it's a soft error versus a, oh my gosh, the sky is falling error. Everything is, in our current version, is essentially an error that would prevent you from being able to return information about that member's eligibility or benefits. So for example, if you have a problem generating a benefit, but you can support a member, like the eligibility for a member, we know that the operating rules dictate what you have to return from a out-of-pocket or from a copay deductible coinsurance standpoint. Then we know that you have to give your benefit dates. We also know there's the series of service type codes that are supported in the mandatory piece of the operating rules. We also know we have the 10 or 11 required service type codes that are supported that are required to be supported on a response for the TR3 when you get a 30. So taking all that in mind, you might have had a hiccup in your benefit system for whatever reason. Maybe it just had, like, your benefit system is down, but your eligibility system isn't. And you can return essentially like a partial response. So you might want to return an EB loop with the EB01 of your eligibility information, and maybe it fails because you don't have a patient match, or you don't, on the ID or the name. You would return the AAA at a higher level. But if you can match the patient, you can make a determination on their eligibility. You can say whether or not they have active or inactive coverage for a PPO or an HMO. You can give those those plan dates. But for some reason, you can't figure out, do they have coverage for office? Do they have coverage for hospital? Do they have coverage for chiropractic care? You can return an EB segment, have the particular service type code returned, and then return a AAA within that 2110 loop to advise the reason why you're not giving back benefit details. Technically, that's what should be done. And then one thing that I think has been misunderstood, it's hard to do in some cases, but the expectation is that you return all of the AAA error codes in a given response when you come across the scenarios that would fail. What we don't want to see happen is a provider submit, and I'm going to use a very probably random example. A provider submit, I'm going to use Bob Bowman. His name, Robert Bowman, submits it with Bob Bowman. In the system, it's Robert Bowman. And for some reason, you reject it because the ID, the first name, and the last name, one of the required alternate searches, doesn't match in the first name. And maybe you require all three pieces. So you reject the Bob Bowman because it's not Bob in your system, and it becomes Robert Bowman. If there was no date of birth for you to validate, you couldn't error it. But let's say they submit all four pieces based on the primary required search, which is the last name, first name, sub ID, and date of birth. And let's say Bob Bowman was submitted with 1 day or 1 year difference from his real birth date. And you fail it on the Bob Bowman because maybe that's your first cascaded search. And you don't even recognize that the date of birth is a fail too. So you send back that, no, we don't have a Bob, and they correct it to say Robert. And then when they correct it and resubmit it and send back, hey, date of birth is wrong, now you've just had to support 2 inquiries and disrupt the provider. Maybe for a system issue on their end, maybe someone fat fingered something. But if you would have caught that error up front, knowing that maybe the ID and the last name did match someone, or maybe the ID did match someone and none of the pieces of information matched, you could have responded saying none of these match. The last name doesn't match, the first name doesn't match, or the first name doesn't match and the date of birth doesn't match. So that way it gives an indication to the provider that there's potentially 2 pieces of information they need to correct instead of having to do it piecemeal. Everett, I don't know if you have something from your velocity and or Optum validator standpoint of what you see.
Not, you gave a very thorough response as far as I'm concerned. There's really not much to add to that. People get typically in many cases, if people get a AAA error, they're not going to really get much more information than that. They're just going to simply get an error back. I've seen instances, and we have AAA messages generate from different systems, and they'll validate just fine in different ways. One system I've seen generate will go down, for example, into the subscriber, and they'll do a check just fine, and then they'll go into the dependent, when that's actually where the request is, and they'll fail it out there, but they'll still provide information. But I've seen other systems that if there's a failure at all, it doesn't really provide any EQ information at all. So it's really different on different systems. So I wish I had a better answer than that.
No, I think it's helpful too. Thank you, Don and Everett. I think looking at the next slide just gives you an idea. I know I could go through this in detail, but the core operating rules do have specific requirements, just as Donna and Everett mentioned, that if there's perhaps issues with the data that came in, a fat finger member ID and a Bob instead of Robert, or Jill instead of Jillian type situation, or the last name has an apostrophe, O'Brien. There's rules related to how that data should be augmented when it hits your inbound system, and if there's issues or problems, to send back certain specific errors. And the operating rules describe, I think, 17 different scenarios and what type of error code, which AAA error code should go back, so the provider knows exactly what data he or she needs to change to make sure that the transaction can come in more cleanly. I think also important in the requirements, and Donna mentioned this, is that you don't want the provider have to correct one thing, submit, oh, it's still wrong, resubmit, right? We want to make sure that as much data as possible from the inbound system, that clearinghouse or the health plans front end, can scrutinize as much of that data on the inbound transaction as possible and return all of the AAA error codes so the provider knows all of this needs to be corrected before I can actually get a valid response. So that's really helpful, right? So building and requiring health plans to have a sophisticated enough front end to identify each of those errors as discreetly as possible and find the most explicit AAA error code so that the provider knows exactly how to action that data on the next transaction and get a clean response back out. That's the intent of the operating rules. Again, building on the requirements within and the availability of error codes within the transaction itself, but making very specific scenarios on the business side of how that should be reported back to the provider, so the provider knows exactly how to make those edits and updates is really helpful. I know we're getting close to our time. We're reviewing our Q&A panel. Any other questions, please submit those. We're going to move into maybe a little bit of a wrap up, and I'll shoot from the hip here and say, and Donna and Everett, please add on. One thing that is great about being a participating organization within X12 and CAQH Core is that you get to work with your colleagues in the industry to tackle these tough problems that we just shared today. So I'm going to raise that for everyone on the call today. If you want to deep dive into these issues and just work with your colleagues in the industry in making the next version of the transaction better and actually understanding the current version of the transaction that we've all implemented, your colleagues in the industry have years and years and years of experience, not only on the business side, but also on the technology side. Working together, we're building the next great version of X12, really understanding the business issues. Donna or Everett, anything else to add about your experience with X12?
Well, I can say in my experience with X12 is it's evolving. I've been involved in X12 for 22 years, and it has evolved from something that was, very simple. Nobody really got into a lot of the complicated discussions about eligibility or benefits. There wasn't, and who would have thunk that 22 years later, I guess we should know better, that the internet was going to be such a big workhorse and that different policies and plans were going to have so many customizations. And so what we have found is, we have a lot of the same people that have participated for many, many, many years, many of which are on these calls right now. And then we have a lot of new players and a lot of new participants. And we need to have those verbose discussions because we won't be able to tailor the implementation guides to meet the needs of the different industries and the different industry needs without having input from those industries. So if there are new complicated benefit structures that your organization is designing that can't be accommodated today, we can't magically fix it unless those topics are brought to us for us to discuss and come up with ways to solution it, to make it so it's not necessarily a one size fits all, but that it is a one size fits most, and then find out how do we fix it for those that it doesn't fit either. And then the second thing is, there's a lot of open discussion, but you don't necessarily have to be a member of X12 to find out, if something is entertained. The entire process to make a maintenance request or a request for change to the Tier 3 is open to anyone. You don't have to be a member. It just really helps if you have a direct line into X12, so when those topics and requests for change are being contemplated, that there is enough information that we help you, the potential non-member, to get what you need, and then balance it with the folks that are sitting at the table and very, very involved in the lively discussions and have it work for them. So while we want more members to be participating at X12, it doesn't necessarily mean you have to be a member to get a change through. And we request that anyone who has anything that they want to have accommodated, put in those maintenance requests, because it's the only way we're going to find out where the gap is. That's all I have. I don't know if Everett has anything else to share.
Just a super, super quick plug. If your organization already has people that are part of X12, that doesn't mean your needs are necessarily going to be fully represented. I may represent a different part of Optum than someone else does. And so we can use multiple people from given organizations just because you may have a specific request that would never occur to me. And so having a better representation like that really never hurts anyone. And all of what Donna said, I 100% agree with.
Great, thank you.
I paid him to say all that, so.
We'll
and
see each other in January, so yeah.
Yep.
And at this time, we'll also take a quick opportunity to plug CAQH core participation. Donna and Everett, not only do they work hard at X12 in their day jobs, they also help support CAQH core in our efforts too. So we have a lot of opportunities going on and lots of things going on within the industry. So that includes we're running pilots and ROI assessments with implementers of the operating rules and the standards. We have entities that go through core certification, ensuring that their systems can meet both the standard requirements as well as the requirements of the operating rules. By demonstrating that, they can then use the seal to help actually procure more customers and ensure that the providers can obtain the data that they need when they need it, right? Again, all of our discussion is about the data. And again, that participation is really important for us as well because it helps us, just like X12, understanding the business needs that overlay the standard. And hopefully from today's session, you learned from our great speakers that the standard has lots of flexibility and lots of capability. The implementations limit some of that just naturally because it's hard and the systems are usually older and it takes a lot of dollars to remediate them to meet the abilities and capabilities within the standard. So the operating rules kind of layer over the standard to help move the industry towards getting and opening up some of those levers within the transaction so the data can flow better for providers. So again, working with X12, working with CORE, we're understanding the needs of the industry and supporting that through standards development and through operating rule development. So with that, I'll thank everyone for attending today. Hopefully you found something that you can take back to your own organization. And again, look out for our next in this session. We'll always enjoy working with our compatriots at X12 and ensuring that we bring education to the industry related to these topics. So thank you and have a good afternoon.
Thank you.